but you can still answer them independently and see how you compared to the audience that was there previously. Now, Ashley will join us at the end of the video presentation to answer any questions you might have live. And so remember to submit your questions to the Q&A. So let's go on from here. Once again, Ashley developed this presentation. She is an adult endocrine physician assistant and adjunct assistant professor at Midwestern University in Phoenix, Arizona. She is also the immediate past president of the American Society of Endocrine Physician Assistants, and also, impressively, the 2022 and 2019 America's Top PA Award winner. Congratulations, Ashley. In terms of her disclosures, you can see them here, that all of these conflicts of interest have been mitigated. In terms of learning objectives, there's the end of this presentation. We hope that you're going to be able to accomplish the following. We're going to review the current osteoporosis screening recommendations as well as diagnostic criteria. Also, we want to discuss a comprehensive osteoporosis treatment plan to include lifestyle and nutrition, fall prevention and precautions, and pharmacologic intervention. And lastly, we want to individualize the approach to the patient with osteoporosis based on some unique risk factors, medication history, and patient preferences. And with that, let me reintroduce Ashley. You want to say anything?
Well, thank you. I'm so glad that we're able to present this program again. It's such an under-recognized condition. So I'm excited to be here to answer even more of your questions. So go ahead and submit them throughout the program, and we'll capture those at the end.
All right, so we'll see you at Q&A. Please roll the video.
So we're here today to talk about osteoporosis. And one of the most important things to talk about when we're broaching this topic is the impact of osteoporosis, because it's a silent disease. So it often doesn't tell us anything until there's really a problem. So we want to put primary prevention as a forefront, because if we don't, the impact of osteoporosis can be quite huge. So we have the risk of fragility fracture, but it doesn't just end there. Associated with that fracture, we have hospitalization, very likely, significant cost. And then we have some residual sequelae like impaired mobility, which could significantly impact a person's ability to live independently. It could affect their depression and their rates of mental health disorders. And something that is so important to recognize is that by 1 year, we still have significant risk associated with this. We have a 24% risk of mortality still at a year's time, 85% risk of loss of mobility, and 3 times increased risk of having a second fracture after that sentinel fracture. So the same thing like we talk about in heart disease, we want to prevent that first fracture from occurring. A little bit more about the impact. So it's important to know that we do see increased risk associated with loss of bone density. So to put that into numbers, 10% bone loss is associated with about 2 times risk of having a vertebral fracture, 2.5 times risk of hip fracture. But what's important to know is that the amount of fractures that we have, the majority actually occur with moderate bone loss. So we're not just waiting for those very, very low scores, those really severe cases of osteoporosis. The majority of fractures are happening in that moderate loss of bone density kind of frame. So osteoporosis, believe it or not, results in a fragility fracture every 3 seconds. These fractures are happening right now, and a lot of them are not being captured and treated afterward. To separate it out by male and female sex, we have 1 in 3 women and 1 in 5 men that will have a fragility fracture related to osteoporosis over the age of 50 years old. And so we see that if they have a prior fracture, their overall risk of having another fracture, not just within that year, but their overall risk of having a fracture is 86%. Again, not related to the degree of bone density loss, but actually related to the sentinel fracture site. So as you can see here, a spine fracture has an increased risk of having a second fracture over hip fracture, and then humerus fracture and forearm, so on. What's so important and something that we need to acknowledge as healthcare providers, regardless of what specialty we're in, primary care, women's health, any specialty that we're in, that 80% of people that have had a fragility fracture are not screened, are not identified as having osteoporosis, and are not treated afterward. That's a huge gap that we need to close. If you want to compare it to heart disease, like we just talked about, the risk of having a fracture after a recent hip fracture is about 8.3%. We're having a second MI after your initial MI is about 9.2%. So very similar overall risks of having a second event. But here we can see the disparity in those who receive treatment. 96% of people leave the hospital with a beta blocker after they've had an acute MI, but only about 23% of people actually leave the hospital after a hip fracture with osteoporosis medication or are treated afterward for it. So again, just narrowing this gap. We have so much information about MIs, but we are missing osteoporosis. So how do we not miss it? We all know about DEXA scans. That's a gold standard here for specifically evaluating and monitoring of bone mineral density. That's not necessarily the gold standard for diagnosing osteoporosis, but it can be used for it. But the gold standard for evaluating bone mineral density. It is a marker for fracture risk. I always tell my patients, I don't care about a number on a page. If you fracture, then that's the most important factor, regardless of what the number shows. But we do know that 10% bone loss is associated with approximately doubling your fracture risk. Typically, we measure the lumbar spine and the typically left femoral neck, but we do want to add that parathyroid, that forearm, that distal third of the forearm if we're suspicious of parathyroid dysfunction. One way to diagnose osteoporosis based off of the DEXA scan is to look at the T-score. And normal T-score is negative 1.0 or higher. Osteopenia is anywhere between -1 and -2.5, and then starting at -2.5 and below is where we can diagnose osteoporosis. Most of us are very familiar with this. We'll talk a little bit more about different ways to diagnose osteoporosis here in a bit. So who should be getting a DEXA scan? This is a little bit of an update within the past couple of years. So I'll refresh on some of the guideline directed criteria for completing a DEXA scan. There is a little bit of heterogeneity, but I can kind of consolidate that for you to make it simpler to really apply in clinical practice. So ACE, we have a couple categories of folks that do need to be screened with a DEXA scan. So all women at least 65 years old, post-menopausal or perimenopausal women with risk factors. We'll talk about some of those risk factors here in a moment, but there are things like low body weight, significant smoking history, history of low impact trauma, or actually alcohol use. Current alcohol use are some of the risk factors that we look for. And then secondary osteoporosis. So that is those folks with parathyroid dysfunction, if we're concerned about that. Prolonged or untreated hyperthyroidism. Actually, diabetes is another risk factor for secondary osteoporosis, primarily type 1, but also for type 2. And then hypogonadism is another risk factor as well for secondary osteoporosis. Bone Health and Osteoporosis Foundation, formerly NOF, the National Osteoporosis Foundation, includes a little bit more. So we are also seeing what was missing in the ACE guidelines are men. How do we screen men? So they're very similar to ACE in that all women at least 65 years old get a DEXA scan, but then all men at least 70 years old. And then based on those risk factors, both postmenopausal women and men that are at least 50 years old. ACP limits it really the most to, again, that 65-year cutoff for women and then postmenopausal women who are at increased risk. So the way to kind of summarize this, because there's that little bit of heterogeneity, I would recommend really whatever captures the most people because we are missing so many of these folks. So I kind of use a little bit of a combination, but if I'm trying to justify having a male get a bone density scan, I'm going to cite the Bone Health and Osteoporosis Foundation versus if I'm concerned about secondary osteoporosis, I might cite the ACE guidelines, but really making sure that knowing what those risk factors are, and then definitely any women above 65 and men above 70 are captured. So in terms of screening, we can't just leave it at the bone density scan. The recommendation for in the guidelines is actually to include a fracture risk assessment calculation. So there are some validated tools that we will talk about here in just a moment to actually assess the 10-year risk of having an osteofracture. So we get the T-score, and then the second step is to assess that FRAX assessment. And here are some of those risk factors that we talked about briefly. So low trauma fracture in adulthood, recent or ongoing long-term required treatment, generally termed as about a total of 3 months or more of glucocorticoid treatment. If they're losing height, they have already had a fracture, smoking history. Excessive alcohol consumption is designated at 3 or more units per day. They have low body weight. This is one of the only conditions where actually having a low body weight is a detriment. So the actual weight of the body can help increase the bone density. And then, of course, after menopause. This is not a comprehensive list, but there certainly are areas that we need more study and questions I often get asked, things that I'm thinking about as clinicians. Should we be screening some of these folks earlier that aren't necessarily in the guidelines? So folks with a history of eating disorders, folks that have had bariatric surgery before, so we know there's some malabsorption involved there, long-term depot injections, premature ovarian failure. We know if they have menopause a little early, we know that we need to screen, but if they have premature ovarian failure, they could be quite young, and we don't necessarily have data about how young to start screening. Males, as you saw from the guidelines, most of the guidelines talk about females. So male sex, it needs a little bit more information, and then diabetes, which we know is a risk factor, but we don't exactly know why or exactly how much of a risk factor it is. So this is that fracture risk assessment tool. If you've got calculators, med calculators saved, wherever you have those saved, add a FRAX calculator. This is designated by country, so you can narrow it down to the country that you are practicing in. One limitation is that it only covers white, Black, Hispanic, and Asian populations. So we are missing some ethnic minorities such as Native American, Southwest Asian, and North African descent. So we are missing those. I do still use it, but just keeping in mind that idea that we just don't have the validated tool for that those ethnicities so far. So it's actually quite simple. It calculates it all for you. Just input, kind of plug and chug, input all the information that you see here, what their height and weight are, because we know that BMI does, in fact, impact bone density, their weight and their height, their sex, and then all of the risk factors that we've talked about. And then you actually put in their femoral neck T-score. And that calculates a 10-year probability of having a fracture related to osteoporosis. So why is this fracture risk assessment tool important? Well, there are a number of ways that we can actually diagnose osteoporosis. So first of all, we have in the middle our T-score. We're all very familiar with that. -2.5 or below, we've got osteoporosis. However, if somebody is that in between area, so between -1.0 and -2.5, but they have a high FRAX score, that is diagnostic of osteoporosis as well. So what's a high FRAX score? It's an overall fracture risk of at least 20% or a hip-specific fracture risk of at least 3%. Either one of them. You don't need them both to be elevated. That is diagnostic of osteoporosis. Or any fragility fracture. So again, numbers on a paper are only numbers on a paper. We're not telling somebody that they don't have heart disease if their cholesterol is normal and they've had an MI. So if you've had a fracture, a low trauma, a fragility fracture, you have osteoporosis. Very similar for Bone Health and Osteoporosis Foundation. We've still got our T-score designations. We've still got osteopenia with high FRAX, the same numbers, over at least 20% and at least 3%. But then they specify that a hip or vertebral fracture specifically versus any low trauma fracture. But regardless, a low trauma fracture, we're dealing with osteoporosis. Such an important part of the treatment of osteoporosis is the nutrition and lifestyle recommendations. When I start talking about treatment of osteoporosis, this is the first thing that I start with. I tell them straight out, regardless of prescription or not, one of the biggest things that we need to talk about for treatment is nutrition and lifestyle. So let's talk about what that means. So unfortunately, we hit our peak bone mass relatively young. So this is a conversation we need to be having earlier about preventing as much as possible. So making sure calcium and vitamin D intake during childhood and adolescence is appropriate. And there are age-based recommendations about the quantity, and dietary intake is preferred. If you can't meet that, then calcium supplementation can be given. Maintenance of normal body weight. So we want to prevent underweight, low weight and low BMI, low body weight. That's a risk factor for osteoporosis. If another reason for smoking cessation, it's another opportunity to have that conversation because of the impact of bone density. Limit alcohol use. So that cutoff that we talked about is 3 units or more. And actually, so the recommendation is to have women have 2 or fewer units of alcohol per day in terms of osteoporosis risk, and men is 3 or fewer. Physical activity. This one's a little bit trickier. So we do need weight-bearing exercises. So some things that are great for cardiovascular health, not so great for bone density, are things like swimming or biking or the elliptical. We're really not getting that impact. We need weight-bearing exercises. Something as simple as walking can help with bone density. And then maintenance of regular menstrual cycles. So that in for your female patients, that supply of estrogen is so very important, which is why menopause and certainly premature menopause are risk factors for low bone density. And then a hormone replacement therapy we'll actually talk about toward the end of the program and its role in prevention. So these are those specific parameters that I just talked about. 2 units or fewer for women and 3 units or fewer for men per day. I would argue probably a little bit less for men because of that FRAX calculator. It starts the risk at 3 per day. Smoking cessation, weight-bearing exercises. So weight-bearing exercises actually help the bone density itself, but there is great value in balance and resistance training for fall prevention as well. And there are actually physical therapy programs that are designed to help to design exercises that improve bone density. So I encourage you to look at or even talk to the physical therapy facilities in your area to see if any of them do have osteopenia and osteoporosis specific programs, because they absolutely do exist. And then fall precautions. It's a lot harder to fracture if you don't fall, not impossible, but if we can help prevent falls, that does decrease the risk. So some of the things we think about with fall precautions are things that we might be doing. So if we are over medicating with antihypertensives or diuretics, we're dealing with volume depletion, more likely to fall. If we have any sort of imbalance or neurological disorders or movement disorders that can increase that fall risk, those are folks that, even if we're dealing with osteopenia, I might talk to about treating with pharmaceuticals earlier because they are at higher risk of fall. Visual acuity, making sure that they have those assistive devices nearby. Limiting CNS suppressants and trying to limit the amount of the medications or the conditions that can cause nocturia, because that's kind of classic. Somebody wakes up in the middle of the night, they don't grab their glasses, they don't grab their cane, they just think the bathroom's right there, and then they end up having a fall and fracture. New for January of 2024, I think this was kind of intuitive to all of us, but officially it was stated that benzodiazepine receptor agonists do increase the risk of fracture. So we want to really limit those. That's already in the Beers criteria, but it is something specific for fractures that we need to be concerned about. And then simple things like securing rugs, tacking down the corner of your rugs, lining walkways and hallways. Caution with pets, not just little pets. I've had folks who tripped over full-size Labrador retrievers and have fractured. So we need to keep an eye out for pets, keep that walker or cane or any assistive devices at the bedsides and at stairs, anywhere where they might need them the most. Nutrition recommendations, again, regardless of prescription or not, we need to be talking about calcium. The best way to get calcium is from the diet. So if we can track dietary calcium and reach our goals, that's the perfect way to do it. If we are tracking calcium and we're not quite meeting those goals, that's where we supplement with extra supplemental calcium. So we are tracking, we're tracking calories, we're tracking our water, some people are tracking their glucose and their blood pressure, they're tracking a lot of things. So my recommendation is just for 1 week, eat your typical diet, and track how much calcium you intake. And if you're meeting that requirement, great. We know with your typical diet, you're meeting your calcium intake. But if you're not, then that's when we add that calcium supplement in. And the recommendation is a little bit that I usually give my folks between 1,000 and 1,200 grams daily, but split to between 500 milligrams a day. That's because we don't absorb a dose of higher than 600 milligrams at a time. So if they're taking it all at once, they're only absorbing about half of it. And this equates to about a 15% reduction in fracture risk. And of course, most of those calcium supplements come with vitamin D, but if they don't, we add that 600 to 1,000 international units daily, and then of course adjust based off of their vitamin D level. Common question I get asked is, well, I don't have dairy, so there's no way for me to get calcium from that diet. And that's fortunately not true. Here's, again, not an exhaustive list, but a common list of foods that contain calcium so that we can encourage folks that don't consume dairy products that they can still get their calcium intake. If we're dealing with calcium supplements, there are some medication interactions that we have to contend with. So tricky. Bisphosphonates, we need to separate calcium and bisphosphonates by about an hour. If they're on thyroid hormone comes first, and then calcium has to come at least 4 hours later. And then iron similarly has to be separated by 1 to 2 hours. So you can imagine if somebody has osteoporosis, is on a bisphosphonate, and is on thyroid hormone, how tricky that might be to time all those medications out. So either significant counseling to make sure we time it out appropriately, or perhaps we select a different medication that we'll talk about here in a bit. Another common question that I get is cardiovascular risk. We try to get calcium from the diet to minimize that risk altogether, but it is still a bit of a controversial topic. Routine recommended intake, so not super physiologic, but recommended intake of calcium via dietary calcium is considered relatively safe. The exception could be in severe kidney disease because of the dysregulation with calcium there. If we're dealing with calcium supplements, we have a few different sources, so I often get asked which one's the best. First of all, thank you for taking your calcium and asking about it, so that's the first win. Calcium carbonate is usually the least expensive and the most readily available, so most folks end up taking calcium carbonate, but you do have to take it with food, and we have to contend with possible constipation, and it does require acid to dissolve. So that could be a little bit tricky. Calcium citrate, on the other hand, has lower available elemental calcium per tablet, so they're often consuming more tablets, which means it tends to be a little more expensive, but we don't have the same GI side effects and considerations as calcium carbonate. Those are the two that I typically recommend. I don't typically recommend the other types, although they are available because of the amount of available absorbable calcium. All right, so you've identified osteoporosis. You've correctly been able to identify it by T-score, by FRAX, or by fracture history, whatever the case may be. First step is to do an assessment for underlying causes of low bone density. So we don't want to miss something that is treatable. So this is a summary of all of the guidelines put together, what they recommend. The top 4 tabs are what they all agree on, and the last one is what there's some heterogeneity. I will say that I generally do almost all of these with every workup because we don't want to miss something that could be treated. And you'll see in there is included is your intact PTH. So we make sure that we look for that parathyroid dysfunction and then a vitamin D level, of course, for the low bone density itself, but it also can help identify the cause of hyperparathyroidism if that is identified. So this is that underlying workup. We want to identify any underlying causes that could be treatable. Are prescription medications that are available. I want you to think about them in certain categories. I think that will really help when we're talking about all the options and what might be best for our patients. So we want to talk first about the anti-resorptive class. So that is what most of us are familiar with. Our anti-resorptives are what I call for my patients, I call them bone maintainers. So they kind of keep our status quo. The natural trajectory of osteoporosis is down, down, down. So if we can enlist an anti-resorptive to maintain their bone density, then we have already succeeded against that natural trajectory. So those are your bisphosphonates, and that's denosumab, and that's calcitonin. Then we have our anabolic agents, which are your bone builders. That's how I reference them to patients. So those are your PTH analog options, teriparatide and abaloparatide, and then your monoclonal antibody romosozumab. So we have two classes for anabolic agents. And then we have some others which we'll talk about that don't fit into either one of those classes, and we'll talk about where they may or may not have a role. So first, you've got a new diagnosis of osteoporosis. What do we do for initial therapy? The first line, I want to take a moment here to really emphasize osteoporosis and osteoporosis diagnosis by itself is enough to designate a high risk of fracture. There is no such thing as osteoporosis with a low risk of fracture or even moderate risk of fracture. Already having that diagnosis, we're dealing with high risk of fracture. We'll also talk about here in a moment what designates a very high risk of fracture. But minimum, anybody who's diagnosed with osteoporosis, the recommendation is to treat with pharmaceutical intervention. Our first line agents are the majority of your bisphosphonates, so alendronate, risendronate, and zoledronic acid. And then what is an update on the recent guidelines is that denosumab is actually determined to be an alternative first line agent. So first priority would be bisphosphonates, then denosumab. We have a couple of other options like ibandronate. We have that available, but be aware that ibandronate is only specific to reducing the risk of vertebral fractures. And I don't know what kind of population you see in your practice, but typically we're not seeing just a low T-score in the lumbar spine. We're usually seeing lower T-scores throughout. So I favor away from ibandronate because it's so spine specific. And if you are dealing with men who have osteoporosis, we do have specific options that are available to treat men. So alendronate, risendronate, zoledronic acid, denosumab, teriparatide, and abaloparatide. So what you might notice is missing there is one of our anabolic agents, which is romosozumab. So that one we do not have an option to use in men. And then ibandronate is also not an option. If we're dealing with a very high risk of fracture, how do we identify those folks? Who is considered very high risk of fracture? Well, this is actually clearly defined in the guidelines. Anybody who's had a fracture within the last 12 months, anybody who fractures while they're on osteoporosis treatment, that's a treatment failure. Regardless of what the T-score is, that's a treatment failure if they fractured on osteoporosis treatment. They have fractured while they're on drugs that are deleterious to bone health, such as glucocorticoids. They have a history of multiple falls, or they're high risk of falls, or history of injurious falls. They have a very low T-score, which is negative 3.0 or below, and then a very high frax, which instead of a cutoff of 20% for overall fracture risk, 30%. And instead of a hip fracture risk of 3%, we're dealing with 4.5%. So those are our folks that we need to identify not only have osteoporosis, but they have a very high risk of fracture. And that's where the treatment recommendation is to use one of those anabolic agents that we talked about, teriparatide or abaloparatide or romosozumab. So let's walk through each of those agents. First, our anti-resorptives, our bone maintainers. So we have bisphosphonates. Updated in folks with a high risk of fracture, which is any diagnosis of osteoporosis. They in fracture risk of about 50% over 3 years. Remember, despite spines, and we do have some flexibility with dosing. We have weekly options, we have monthly option, and we have a yearly option as well. Some considerations, the oral preparation, so that's everything except for zoledronic acid, does increase the risk of gastric reflux. So you want to screen your patients who already have a history of gastric reflux or GI upset. That might not be the best option for them, but they do have the once yearly IV version, which circumvents the GI tract entirely. They are contraindicated if your creatinine clearance is less than 35. And we all have heard about the risk of osteonecrosis of the jaw and atypical femur fractures. So with atypical femur fractures, what we want to do is after 3 sequential years of IV bisphosphonate or 5 sequential years of oral bisphosphonates, we want to take a year off in that what's called a drug holiday. And that the way I explain this to patients is it essentially gives your body a year to cycle that medication out of your body, get fresh bone in, and then the clock resets. Then we can do another 3 or 5 years. So what does a drug holiday look like? So let's say our patient is on an oral bisphosphonate, on that bisphosphonate for 5 years. And if they're stable at that 5-year mark, their bone density is still holding strong, they haven't had any fractures, then we can just do a simple drug holiday, meaning no medication over that year. And then after the year off, we can resume and that clock resets. Let's say we've identified that they're very high risk of fracture, either because their bone density is declining, they've had a fracture on therapy, or they already were very high risk, but they didn't want to do an anabolic. Well, then we might take that opportunity for that year off of therapy to add something else in its place, like an anabolic agent during that year. So instead of leaving them untreated. So kind of some of that shared medical decision-making, you would have that discussion with your patient to see what would be best for them to do during that drug holiday. Our other anti-resorptive is denosumab, and that, again, is that alternative first-line therapy. So over 3 years of therapy, it does do some significant reduction in fracture risk, which is great. We don't have renal dose adjustment for this medication, but very new this year, we actually have had a box warning added to denosumab for the risk of severe hypocalcemia in advanced kidney disease, the worst of which was seen with folks who are on dialysis. So if we do have somebody with advanced kidney disease, the best recommendation is to have that person followed by somebody who is well versed in treating osteoporosis in that situation. But minimum, we need very close monitoring of calcium levels because there were some hospitalizations related to low calcium in folks with advanced kidney disease. So you need to be very well aware of that. One thing to know about for the general population who might be treated with denosumab is that after 2 years of no treatment, after they've stopped denosumab, the bone mineral density essentially returned to baseline, what it was before any treatment. And we do know that so our injections are given every 6 months, starting as soon as month 7. So we are 1 month overdue. We start to see an increased rate of vertebral fractures. So in general, this is not one of the anti-resorptives that I recommend first because unfortunately life happens. Sometimes people are late getting their injections. Sometimes they're traveling. Sometimes insurance doesn't come through. Things happen. So we need to be aware that we need to be very consistent with this medication to avoid that risk of rebound vertebral fractures. And there is less risk of osteonecrosis of the jaw and atypical femur fractures with this medication, not zero, but less. So therefore, a drug holiday is not recommended because of that, as well as that risk of rebound vertebral fractures. We'll switch gears here and do our first anabolic group, which is teriparatide and abaloparatide, or PTH analogs. So these are for your very high risk of fracture, those with those significantly low T-scores, significantly high fracs, multiple falls, they've had a fracture on treatment, fracture in the last year. We do see a significant reduction in fracture risk and actually an improvement in bone density. These are our bone builders. We do have to screen out those at risk for osteosarcoma, although neither agent has a box warning for that anymore. They actually were seeing that the post-approval rates of osteosarcoma were much lower than anticipated, so they removed the black box warning. And new for the end of 2023, there is a transdermal abaloparatide that's under investigation. We don't have much more information than that right now, but that is potentially going to be another option for our patients. In general, these are recommended to be no more than 2 years in a lifetime. The one exception is teriparatide had that restriction removed by the FDA a couple of years ago. And it's not to say that we can continue this indefinitely, but it's to say if you've identified that somebody continues to be at very high risk after the 2 years, you can have a shared decision-making discussion if that is right for them to continue. You don't have to use the 2 years in a row. You can do 1 year now and 1 year in the future if you would like, but it's those two years in a lifetime that's generally recommended. If you are stopping the anabolic for whatever reason, either because they've used up their 2 years or whatever the reason may be, please follow it up with an anti-resorptive, because the bone density, you want to maintain what they've gained. So if they've gained bone density on the anabolic and then we remove therapy altogether, we've lost everything that we've gained. So after that treatment, we see that bone density goes up, then use one of your bone maintainers, your anti-resorptives, to keep them there. And then romosozumab is the newest kid on the block. It's not so new anymore, but again, it's one of our anabolic agents, so very high risk of fracture. That's where this is indicated. Significant reductions in fracture risk, so 73% relative risk reduction at 1 year and a 50% reduction in fracture risks over alendronate. So some pretty substantial risk reduction. Romosozumab does carry a box warning for an MI or a stroke within the last year, so you want to screen that out. That is highly controversial, that box warning. And if we had more time, I could dive into why. But overall, not everybody, including myself, agreed with that box warning. There is some controversial ONJ risk. The studies did not show an increased risk of ONJ, but there have been reports after and post-market data. So we do still give our ONJ precautions for romosozumab. And it was studied for a year. And that's why the duration of treatment is 1 year in a lifetime. That's for efficacy. That's where it stopped. Not because there were increased safety signals at a year, but that's how far it was studied. So general treatment considerations. So we're talking about all these options. What do we do with all of these options? First of all, it's a good idea to make sure that the treatment is working. So monitoring your DEXA scan while they're on treatment every 1 to 2 years. If you're seeing a significant drop in DEXA scan and DEXA scores, then we might consider an alternative treatment. The only guideline that does not it's not in keeping with the other guidelines, and it allows for people to really fall through the cracks if their T-scores are declining and we weren't monitoring the DEXA scan. So treatment duration for benefit. This is important to think about if you've just recently started a bone density medication and then somebody fractures. We do want to take into account that they have to be on the medication for a certain amount of time for that fracture reduction to really be optimized. Luckily, it's only 1 year for risedronate, zoledronic acid, and romosozumab. But our other bisphosphonates and denosumab are actually 3 years where we see the maximum benefit. That's not to say there's no benefit before that, but that's where the maximum benefit is. And then it's about 18 months for our PTH analogs. So if you're thinking, I just gave somebody a zoledronic acid infusion 2 months ago and then they fractured, it really hasn't had its time to be fully beneficial. So that's something to keep in mind. This is not within, this flowchart is not within the guidelines, but this is kind of a summary of, how clinical practice works with treating osteoporosis and kind of putting all the pieces together from the guidelines. So if we have our patient who's at high risk of fracture, then the usual recommendation is to go ahead and start with that anti-resorptive agent, so those bone maintainers. Your primary would be a bisphosphonate. The alternative would be denosumab. And let's say their DEXA scores are stable, then we can continue that anti-resorptive until the drug holiday is needed if it's a bisphosphonate. Let's say their bone density is declining. You might transition over to an anabolic agent, because if they're declining on therapy, that's a pretty significant bone density loss. Similarly, if they fracture on therapy, that's a good time to change the agent as well with some of those considerations we just talked about. Contrast this to somebody with a very high risk of fracture. So that's where we would favor the anabolic agent first. So you could choose either a PTH analog for 1 to 2 years and then follow that up with an anti-resorptive to maintain what they gained. Similar for romosozumab, you could have them take that for 1 year and then follow up with an anti-resorptive. If they refuse or have contraindications for any of these, then you could still do an anti-resorptive agent, although that's not the most favored. It is better than nothing. So we still want to do some sort of treatment if we're able to. And then, of course, with our bisphosphonates, if we have that drug holiday, that's a good opportunity to maybe nudge about the anabolic a little bit more, see if they're open to it at this point. We have a couple additional options that are brought up often that I want to touch on. I'll go through these quickly so we have time for questions. I know we'll have plenty of those. So calcitonin, I'm not asked about this as much anymore, but I do still sometimes get asked about it. It does have some reduction in specifically vertebral for fracture risk. So again, if it's very specific to one site, it's not as favorable as some of the other options. Very rarely does osteoporosis only affect one site of the body. There was no evidence of reducing any non-vertebral fracture risk. And there is a possible link to malignancy that's not well understood or well defined, but because of that risk versus benefit profile, it's generally not recommended. Hormone replacement therapy. I get asked this question a lot from patients and providers. I have osteoporosis. Can't I just go on HRT and take care of it? And actually, hormone replacement therapy is used in the prevention of osteoporosis. It is not indicated for the treatment of osteoporosis. So while, yes, we can use HRT to prevent further decline or help blunt some of the decline, it is not itself an osteoporosis medication. But it's something to think about when you're having that discussion with your patient of risk versus benefits of HRT, that bone density preservation is one of the benefits. So obviously having a well-rounded discussion about HRT is important. Thiazide diuretics are not always thought about in the treatment of osteoporosis. And to be clear, they are not indicated for the treatment of osteoporosis. But what thiazide diuretics do is they actually help the body resorb more calcium from the urine. So this has a net effect of lowering blood pressure, and it helps reduce the risk of kidney stones. So we do see it's not super consistent. We do see some improvement in bone density when people are on a thiazide diuretic. So where this comes into play is if you have somebody who you've identified has hypercalciuria and you've ruled out the normal causes that like PTH issues, or they have hypertension and are at risk for low bone density, you might think about a thiazide diuretic to help preserve some of the bone density. But it is not itself a bone density medication. So let's go through a question, and we have our ARS questions associated with our case study. Mrs. S, who's a real person, 65-year-old female with a history of lupus. Her BMI is 20.5. She's coming in for a follow-up after a screening DEXA scan on her annual exam. The DEXA scan showed her T-score at the lumbar spine was negative 2.0, and her left femoral neck was negative 2.2. Her underlying workup for secondary causes of low bone density was within normal limit, and she's never been on any treatment for low bone density. So based off of this information, what is Mrs. S's diagnosis? Does she have normal bone density? Does she have osteopenia, osteoporosis with moderate fracture risk, osteoporosis with high fracture risk, osteoporosis with very high fracture risk, or I need more information?
All right, Ashlyn, you're all over the place. Osteopenia gets 44.6%, 28% osteoporosis moderate fracture risk, 15% high fracture risk, 4.6% I need more information. So the majority say osteopenia. What do you say?
That's a very interesting response. So based off of T-score alone, we would qualify her with osteopenia. However, we need a little bit more information. And remember, C does not exist. Osteoporosis with moderate fracture risk does not exist. Any diagnosis of osteoporosis is at least a high fracture risk. So we talked about in the setting of osteopenia T-scores, what we need to do next is our FRAX. So that's not the end of the story. We need to do our FRAX risk assessment calculator. So for her specifically, her risk factors for low bone density are her age, a history of lupus, although that's not a direct risk. We do need to explore, is she using any glucocorticoids for that treatment? And thankfully, no. She did have menopause without hormone replacement therapy, and she did actually have a previous fracture. So this question number 5 was yes, and that did definitely increase her fracture risk. So she actually fell, did a trip and fall about 8 months ago, and fractured her left distal humerus during that fall. So all of that put together in your FRAX calculator put her overall osteoporotic fracture risk at 17% and her hip fracture risk at 3.2%. So given this information, let's reevaluate what her diagnosis might be. Again, we have normal bone density, osteopenia, osteoporosis with moderate fracture risk, osteoporosis with high fracture risk, or osteoporosis with very high fracture risk.
All right, Ashlyn, 58% now say osteoporosis with high fracture risk. Moderate fracture risk, 25.6%. 10% still say very high fracture risk.
So that 10% has it. So we have a couple of things that clue us in here. So the FRAX score for her hip automatically put her into osteoporosis at 3.2%. So anything 3% and above for the hip FRAX risk is an indication of osteoporosis. We have this very important extra information, though, that we have that this recent history of a humerus fracture. The humerus is a pretty significantly strong bone, so especially after simply a trip and fall, that should not have fractured. But she has fractured within the last year. So we talked about how there's that significant increase of a second fracture risk in the 12 months following that sentinel fracture. So this bumps her, this history of a fracture within the last 12 months, a fragility fracture, does put her at very high risk of fracture. So that is essential to identify that she is in a prime time where we need to step in for her. So given that information, you ask a little bit more history, you do your counseling on lifestyle intervention. We talk about calcium, we talk about weight bearing exercises. She's actually doing quite well with her exercises. She exercises daily for 30 to 40 minutes with strength training. She has no history of multiple falls, no underlying conditions that would increase her risk of falls. She does intake dietary calcium, but doesn't know how much, and she takes a multivitamin each day. So given all of this information, putting it all together, what would be the best treatment plan for Mrs. S? Would you encourage her to work on the weight-bearing exercises and start taking OTC calcium supplementation? Would you recommend alendronate or bisentronate? Would you recommend zoledronic acid, recommend denosumab, romosozumab, teriparatide or abaloparatide, or HRT?
All right, Ashlyn, 15% weight-bearing exercise and calcium supplementation. 50% say, let's go to alendronate or risendronate. And then you have about 11% for denosumab, romosozumab, 4% zoledronic acid. Teriparatide gets 7%, and nobody wants to take HRT.
Very good. So they got the message loud and clear that HRT is used for prevention, not for treatment of osteoporosis. So you've identified Mrs. S as being at very high risk of fracture. So in that situation, the best course of treatment would be an anabolic agent. So either romosozumab or your PTH analogs, so either E or F. And based off, assuming there are no contraindications, either one of those would be the optimal treatment. You could do an anti-resorptive if she really deferred the anabolics, because that's better than doing no treatment. But remember, any diagnosis of osteoporosis, treatment with pharmaceutical intervention is recommended. Patients have, of course, the right to refuse that, but the recommendation is to treat any diagnosis of osteoporosis and to identify those at very high risk, like Mrs. S. She would best benefit from an anabolic agent. So she's successfully treated with romosozumab for a year. Thankfully, we have no fractures while on treatment. That is one of the questions I ask every single osteoporosis follow-up, because regardless of what the numbers are showing me, I ask, have you had a fracture at all since we last talked? And if they have, explore the conditions in their with it. She's doing great, continuing her weight-bearing exercises. She does 100 milligrams twice a day, the dietary and supplemental calcium. And now her DEXA scan shows a T-score. Lumbar spine is at negative 1.5, and her left femoral neck is negative 2.0. So what is the best treatment plan now for Mrs. S? Would you continue her romosozumab for another year? Would you switch to teriparatide or abaloparatide? Would you do 1 year off treatment and keep up with those great weight-bearing exercises and calcium supplementation? Or would you transition to a bisphosphonate or transition to denosumab?
All right, Ashlyn, still a variety of opinions. Leading the way is romosozumab for 1 additional year. 22% said 1 year off treatment, continue weight-bearing exercises and calcium. 27% transition to a bisphosphonate, and then 8% transition to teriparatide, and 7% transition to denosumab. So your leaders are romosozumab and bisphosphonates.
Great. So let's talk about that a little bit and unpack each of these. So for this situation, there are a couple of options, some better than others. Definitely transitioning to bisphosphonate is one option. And one important thing to identify after an anabolic agent like REB or PTH, follow that up with an anti-resorptive or maintain the gain, as it were. So we don't come up with an anti-resorptive, we typically will lose that bone density that we had gained. So following it up with something is important. Romosozumab is only indicated for 1 year in a lifetime at this point. In the future, that might change, but right now we're stuck with 1 year. So we can't do A. We could transition to teriparatide or abaloparatide. That's not a bad option. However, with how much improvement she had in her bone density scan, we don't necessarily need to be as aggressive now with abaloparatide. She's out of that year post-fracture. Her T-scores are improving. She's not fractured on treatment. So overall, we could really do something else like a bisphosphonate during that year. Teriparatide or abaloparatide is not wrong. I just don't know that we need it at this point. Transition to denosumab would be lower on the list because it is that alternative anti-resorptive that we've talked about. What I want to avoid, though, is C, coming off of treatment for a year. We don't want to lose. We have only 1 precious year with romosozumab and 2 years with our other anabolic group. So we don't have the opportunity to repeat this. We have to maintain what was gained. So I would put either D, maybe a close second as B, as the best options here. So bottom line, summing this all up in a very short 1 slide, making sure to screen everybody that qualifies for low bone density with a DEXA scan. So that's all women 65 years and older, and consider women and men at least 50 years old. I would argue to try to include men so that they do not fall in that gap. But if you identify anyone 50 years and older that has that, some of those risk factors we talked about, get a DEXA scan. Remember to use your FRAX score in the diagnosis. If you've got low T-scores or you've got a fragility fracture, you know your diagnosis is osteoporosis. But if we've got osteopenia, we need to add that FRAX score in. And remember that any low trauma fragility fracture is diagnostic of osteoporosis, regardless of what it says on paper. If they've had a fragility fracture, they have a high risk of fracture, so they have osteoporosis. Any diagnosis of osteoporosis is designated as a high fracture risk, and therefore pharmaceutical intervention is recommended. If you identify somebody at very high risk, like our Mrs. S, that is when the anabolic agents would be recommended first. Keep in mind how long we can treat these folks with different agents safely. how long they're indicated for, and how long it takes for efficacy to take place. Don't forget the lifestyle factors, fall precautions, your calcium and nutrition intervention. That's so essential, regardless of which agent is chosen. And if possible, prevent that sentinel fracture from happening to significantly reduce the risk of the hospitalization, the cost, the mobility considerations, the morbidity, and those subsequent fractures. Prevention is key.
Excellent. I can see why that was a popular demand request. That was excellent and certainly very comprehensive. So even though you covered everything, there's still a lot of questions because it's obviously a very common problem that we see. So let's jump into it. Lisa asked a question about is there value to the FRAX scores, even though the DEXA scan says the patient has, the T-score suggests the patient has osteoporosis. Why do you need both?
It's a great question. And you don't need the FRAX score for a diagnosis of osteoporosis if your T scores already qualify. The only area that it could be helpful in is identifying those who are that very high risk that might be more benefited by an anabolic agent. So as we talked about, that very high risk would be that FRAX score, an overall osteoporotic fracture risk of over 30% or a hip fracture risk of over 4.5%. So that would be the only value, but we don't need it to diagnose if the T-scores qualify.
Great, thank you. So Tammy asks, if the patient has a calcium score of 10.5, is still need to continue these calcium supplements?
That's a great question. So our serum calcium level, the body tries really hard to maintain that in a normal range. So a serum calcium level doesn't necessarily represent whether that calcium is sufficiently stored in the bone. So that by itself is not a good marker for how much the bones have in terms of calcium. I would encourage you to do a corrected calcium. So you adjust for the albumin level to make sure we have an accurate calcium level. And if it truly is slightly high like that, making sure to, of course, work up the high calcium level, but we can sometimes see an elevated calcium level or an elevated ALK phos level in osteoporosis because of that higher bone turnover. So those marginal elevations, I would say first correct for that with albumin and then work it up if it's a true hypercalcemia, but that doesn't really represent if that calcium is in the bones. It may be being pulled from the bones to maintain that serum calcium level.
Good point. Thank you. There's a question here. I think everybody's a little terrified about the issue of dental, dry socket dental problems. The question is, if a patient has to have extensive dental therapy, how do you modify their therapies? How much of the Fosmax do you need to skip, or do you postpone? What do you do?
Oh, great question. So first, counseling beforehand, get that dental exam beforehand, identify any issues if you have the luxury of having some time there. Routine dental work, routine dental exams is highly recommended with these agents. And in general, we try to wait and hold the medications for about 6 months before doing any invasive dental procedures. Routine dental work is fine. So I tell my patients, caps, cleanings, fillings, go for it. But we're talking about those invasive dental procedures that compromise the jaw. There are situations, though, where it is an urgent issue and it can't wait. And in that situation, that's a hard conversation to have if it just has to occur. But if it can wait, it should wait. Important thing is to follow up once the person has healed and resume therapy when it's safe to do so. And dentists are pretty good about giving you that clearance when we've got it completely healed.
So another complication to think about. Antonia asks about why not use alendronate for men with osteoporosis?
You can use alendronate for men with osteoporosis. So alendronate, risedronate, zoledronic acid, and our PTH analogs, and of course denosumab. The ones that we cannot use in men that aren't approved in men are ibandronate and then the newest anabolic romosozumab. So good clarifying question there.
There's another question here. Basically, Thomas wants to know how long after fracture do you get a DEXA scan?
I love this question. So, a couple of things here. One, after a fragility fracture, we don't need that DEXA scan to diagnose or start treatment. So, I wouldn't hold off on any treatment when you're waiting on that DEXA scan. And the real answer is as soon as the patient's able to tolerate that kind of movement, because as you can imagine, if they've had, a vertebral fracture or hip fracture, their mobility can be impaired for a while. So when they're able to, it helps to kind of establish that baseline T-score so that moving forward, we know if they're responding to treatment or not. But that fragility fracture itself is enough indication to go ahead and start treatment. And then the follow-up question is usually, when do I start treatment? And the short answer is as soon as possible. In fact, even before they leave the hospital, you can start on treatment. The one asterisk there is if you're using something like zoledronic acid, which is that once a year IV, there is a school of thought to wait for a short time to essentially give the body time to remodel the fracture a bit more before we deliver a full dose for a year, because the thought is we don't want that fracture site to take up the majority of the medication. So in general, in clinical practice, what I've seen is about 2 weeks later to do the IV. But if we're talking oral medications, we can go ahead and start right away.
Okay, and let me give you one last question, just from Linda. The importance of a therapeutic vitamin D3 level, how important is that? And also the need for supplementation with calcium in those patients.
Absolutely. So our low vitamin D has many implications. It has physical implications such as, musculoskeletal pain. Of course, it affects your calcium absorption. So if our vitamin D is low, we may be intaking the calcium and not actually absorbing it. And kind of the downstream effect is with that, those kind of chronically lower vitamin D levels, we get kind of chronically lower serum calcium level. So the body tries to maintain that serum calcium level, and it'll do so by bumping up the parathyroid hormone to help pull more calcium from everywhere, including the bones. So you may not see the low calcium on the blood test because of the low vitamin D, but it's because we're sacrificing the calcium in the bone. So very important to treat those levels, get them to a therapeutic range for them to be able to absorb the calcium and prevent further kind of stealing from the bone. Calcium supplementation for anybody who has a diagnosis of osteoporosis, the recommendation is that calcium supplementation is recommended if we aren't meeting the levels with dietary intake. That can be a little tricky. Most people are willing to track it for a week, but I do have some folks who say, I'm not going to track that. Just give me the supplement. And in general, that's considered safe. The exception would be there's some data to show in CKD there is higher cardiovascular risk. But in general, osteoporosis is enough of a risk itself that the calcium supplement is recommended.
Well, Ashlyn, once again, thank you for this fantastic presentation, sharing your experience and expertise. I'm sure this is very helpful to our attendees. Let me tell
thank you for all the questions. I love the interaction. So thank you for submitting all those questions. And thank you, Stephen.
My pleasure. So under course materials from the Bone Health and Osteoporosis Foundation, there's a resource page being added, and that will be a very valuable resource for your practice. So I'm Dr. Stephen Brunton, and this concludes our presentation and our CMEC program for today. I want to thank all our supporters, faculty, moderators, planning committee, and production team. They all contributed to make this activity a real success. And thank you to all of our audience who participate today. We appreciate you remaining engaged, your great questions, and really staying involved. And we hope we're able to give you essential information on hypertension, lipid management, CGM, and osteoporosis care. Now, also, you should check out our NACE Journal Club, the NACE podcast channel with Dr. Neil Skolnick, and the APAP podcast episodes with Dr. Corinne Young. You can access these by clicking the link provided under resources. Now, remember to sign up for our next live symposium on emerging challenges and clinical updates in primary care next Saturday, April the 20th at 9 a.m. Eastern. Click the sign up button in the blue box on the left side of your player window to register. Thank you for attending today's virtual symposium. stay safe, and have a great rest of your weekend.